Hello, and welcome to the Health is the Key podcast, where we explore the health and wellness issues that matter to 1199 SCIU healthcare workers. I'm your host, Elizabeth Moore, and today we're taking a look at type 2 diabetes, a condition often called a national health crisis, affecting more than 34 million people in the United States, more than a quarter of them undiagnosed. People living with diabetes are often also managing other conditions like hypertension, obesity, and heart disease. Now, as alarming as this may sound, there is good news. Today, we're lucky to be joined by Jessica Vatel, who's here to share that news with us. Jessica is a registered dietitian and certified diabetes care and education specialist in the Diabetes Care Program at the Brooklyn Hospital Center. Jessica works closely with patients living with diabetes, educating them about their condition and helping them develop healthy coping and problem-solving skills to manage it. So we're very excited to talk with her. Welcome to Health is the Key, Jessica.
Thanks so much for having me.
So to get started, as prevalent as diabetes is, we're not sure that many people know exactly what it is. Can you give us a brief overview of the condition?
Yeah. So diabetes is a disease where the body isn't able to keep a healthy level of sugar. The sugar that is in the bloodstream is called glucose.
And we've heard a lot about prediabetes. What exactly does that mean?
So prediabetes is where a person has a greater risk of developing type 2 diabetes. Some people might hear it from their doctor that they have borderline diabetes. So it means that the level of glucose in the bloodstream is higher than normal, but it's not high enough to be considered diabetes. Prediabetes, we measure it using a test called the hemoglobin A1C. And prediabetes is defined as a hemoglobin A1C of 5.7 to 6.4%. Prediabetes can be reversed, or we can delay the onset of type 2 diabetes.
Okay.
And the way that we would do that is we would want to work with our patients on dietary and lifestyle modifications, cutting back on portion sizes, stopping sweet drinks or cutting back on them, being more active, getting more exercise, and definitely working on stress management.
And that leads into my next question. What if you think you have prediabetes? What are the signs and symptoms?
So you're not necessarily going to get symptoms if you have prediabetes. The A1C creeps up. So patients that I work with might have prediabetes for 5 years, for 10 years, for 15 years. And over that period of time, the A1C might be starting around 5.7, 5.8, then it'll move back down. They might work on some lifestyle modifications, but if they gain back some weight or start eating more, exercising less, then the A1C slowly creeps back up. So the reason why this happens is because the insulin in the person's body isn't working well. So that's called insulin resistance. And over that period of time, as the insulin isn't working as well, the pancreas then starts to overproduce insulin. And so then it eventually will give up because it's exhausted. And so that might be the point where the person starts to experience symptoms when their A1C has just kind of gone from like a 6.3 maybe to an 8, maybe to a 10, maybe to a 14, which is very, very high blood sugar. But those people that are kind of in between at that diagnosis, but it's not very, very high, they might not have symptoms. They might notice that they're fatigued or tired. When a person is going to get significant symptoms is when the blood sugars are in the 200s, 300s, 400s, even higher. They're going to get excessive thirst, urination all the time, very dry mouth, not responding to drinking water. It's still dry, they're still urinating. Like I said, extreme fatigue. And then the other thing that they could be on the lookout for is something called diabetes ketoacidosis, which is where the sugar is so high that the body starts to make these unhealthy molecules called ketones, and that person might experience like a lot of nausea, some vomiting, maybe some diarrhea, severe dehydration, just very lethargic. So that would be if somebody has advanced diabetes and their sugars are really high. So it's a little bit more complicated than some people. I have patients who their sugars have been that high and they don't feel like they get symptoms.
Wow. So you really wouldn't know whether you have pre-diabetes or even diabetes unless you go see a doctor and are tested for it.
Yes, definitely. And because there is the genetic component, I think that that's important to be aware of. A lot of my patients are aware if their mom or their dad or both parents, siblings, aunts and uncles, if there's a large family connection with genetics, then the likelihood is they're aware of the risk factor, so they might be more inclined to get checked out. But a lot of times people might not necessarily get that checkup and know.
And so you can develop diabetes without a family history?
Yes.
And what would cause that or bring that on?
That would be living with obesity, living with hypertension, living with hyperlipidemia, so that's like elevated cholesterol levels, elevated triglycerides, being very sedentary, so not moving around a lot, and then also just poor diet.
What kind of challenges does this condition bring to everyday life?
Yeah. Well, I would say one of the first things that kind of comes to mind when you mention that is acceptance. Right? I think that is what I see my patients struggle with a lot, is accepting the diagnosis. And that might be something that they're able to adapt to quickly, and then they just kind of go full tilt into everything, like the medications and the exercise and what they're going to eat and monitoring their blood sugar. But then there's also other individuals that don't necessarily have those coping skills yet. They're just kind of really overwhelmed. And so I think when a person is overwhelmed and they're struggling with acceptance, they might have a difficult time, going to follow-up appointments, maybe, learning how to monitor their blood sugar levels, learning how to take the insulin. That could be overwhelming. I think really finding support and having that kind of personal handoff for a dietitian, a diabetes educator, a social worker, an empathetic primary care provider, a nursing staff that really takes the time to make sure that person has good follow-up, and that who's going to help you with this? Who can you lean on?
And how would a member typically begin? Are they referred? They've heard about the program at Brooklyn Hospital Center and they can just call you up and say, I want to come in? Or
Yeah, so the one caveat right now is that we do want our patients to be having primary care or a specialty care at the Brooklyn Hospital Center. We really want to be able to provide that to our patients who have established care with primary care, endocrinology, podiatry, cardiology, any of those specialties. We do have referrals from any of those providers, and we have a new referral called Diabetes Education and Training. And so that's my baby and my colleague Olivia Schmidt's baby. So we kind of put this program together where we've started our 6-week diabetes class series. The first class is healthy eating. The second class is healthy coping and physical activity, because coping with the disease is, I think, one of the biggest challenges for people who have lived with diabetes a long time. And then the third class is medications. The fourth class is monitoring and problem solving. And problem solving is also, I'd say, very, very important. so that you kind of have skills to handle difficult situations. And then the last class, we're looping back around to meal planning, where we do meal building and we also do a cooking demonstration. They're small classes, so the group setting should only be about 6 to 8 people. Right now, we also have a volunteer who's working with the class, who's taken the class before, and is able to kind of give that experience of living with diabetes, so that I think that's one of the things that's so important, is to have support from peers and to
Someone
have
who's
somebody
been through what you're going through.
Yeah,
Mm-hmm.
a listening ear, somebody to challenge you sometimes. Like, hey, why are you eating that?
Sort of like
you're
a
not supposed
coach?
to. A little bit,
Yeah, a peer coach.
Yeah, and that's different than hearing it from me or Olivia,
Mm-hmm.
because they know they're going to hear that from us because we're dietitians.
Well, it's funny. We had spoken to a member who you had counseled, and she said, she's always on me. She's on me. So I wanted to know, how much contact do you have with a patient that you're counseling?
So I'm going to work with the patient who wants to be worked with, right? And that, I think, can be challenging at times. But when a person is motivated and ready, then once a month. And that could be in person, and that could be over the phone.
And are there opportunities for in-between contact? Like, can they text you? Can they call you with issues? And
Definitely.
Okay.
Yeah. So I think that's really important, because, like I said, this disease can be really, really challenging to live with. And so that's why this program is so vital to our patients, is because I think they feel confident that they can call and leave a voicemail message or a text or receive a text message saying, hey, how you doing? How's it going?
That's important to hear.
Yeah. How's that higher dose of the medication? And that's another thing that diabetes world is changing right now because of the continuous glucose monitors and these medications that now are once weekly injections. Diabetes is very, very different. So I can access my patients' continuous glucose monitor data as I talk to them on the phone, and look at their data and say, oh, okay, well, I see. What did you drink last night? What did you eat last night? I could see your blood sugar was like 300. What happened there? And so I think that it's teaching patients a different way to care for themselves, where it's not just, oh, this is my finger stick right now. This is my blood sugar right now. I know what foods are causing it to go up. I know what I need to do if my blood sugar is going down.
So even with all the new drugs that are out there and all the new approaches, what are the basics of diabetes management?
Yeah, so that's a great question. So the foundation of diabetes management is lifestyle modifications, and that includes being physically active and changing your meal plan to eat smaller portions and avoid sugar-sweetened beverages and sweet beverages. So when we talked previously a little bit about type 2 diabetes and insulin resistance, so the reason why exercise is so effective in helping treat diabetes is because it helps the insulin work better. It's circulating in the bloodstream with the glucose, and its job is to open the doors to the cells and allow the glucose to enter into the body's cells to be used for energy. When insulin doesn't work well, called insulin resistance, that doesn't happen effectively. So there might be insulin in the bloodstream, but when it tries to activate the body's cells to open the door, the cells don't respond. So the glucose builds up in the bloodstream. So exercise is extremely important because it helps sensitize the body to insulin, meaning when it's circulating in the bloodstream and it attaches onto the outside of the cell, it works. It opens the door and the glucose enters the bloodstream or the body cells. And second, when a person is exercising, the body starts pulling the glucose into the muscle cells. And the muscle cells use it for energy. And even after exercise, they still pull glucose into the muscle cells because the muscles store glucose for the next time you're going to exercise. And then when it comes to the meal plan, a lot of times when the provider is seeing the patient, they might tell the patients what they can't eat, which I think is challenging for a patient because a lot of what we eat is tied into our cultures. So that can be very discouraging for them to hear, well, I can't eat rice anymore, but that's what I've eaten since I was a kid. So it's really giving the education, meeting with a registered dietitian, and I would say more than once, to find the motivation and also to find the guidelines and the support that they need to modify the portions on their plate. So eating smaller portions of carbohydrates and starches, eating less fried food and less fast food, eating more vegetables, using different cooking techniques like baking and air frying and broiling and grilling. And then really, I think, watching out for any sweet beverages, even juice. So that is very important and the foundation of diabetes management. Those should happen regardless of if you're prescribed a medication for your diabetes or not.
So this is sort of a question. Can diabetes be, quote unquote, reversed? And what are some of the stumbling blocks to, you have a member patient in your program and they're trying, but what are some of the challenges that you find with your patients that you have to help them get over the hump?
Yeah. So as far as reversal is concerned, there isn't diabetes reversal. Pre-diabetes can be reversed. Diabetes, type 2 diabetes, can go into remission. And so what remission is defined as is an A1C less than 6.5 for at least 3 months without taking any medication. How long a person can stay with remission, it depends on the interventions, right? So maybe this individual was exercising regularly, they lost weight, they're planning their meal plans, they're avoiding sugar-sweetened beverages, they now have no intention of changing that at all. They might be able to stay in remission for a long period of time.
So do you find that patients, for lack of a better word, get tired of the discipline it requires, and that's sort of how they fall off? And I know that the emotional component is big too. That's where the multidisciplinary care comes in.
Yeah, sometimes there's not enough education early on, and I think that's huge. So when you have an individual who has had diabetes for 10 years, 15 years, 20 years, and they're requiring insulin injections, they're requiring to monitor their blood sugar very frequently because they're taking insulin injections, and then they're starting to get complications. It can be very overwhelming. There's a lot of numbers involved, right? There's a lot of planning ahead. Planning ahead, I think, is very important. Are you packing your insulin? Have you been taught how long an insulin pen lasts at room temperature? Do you have your pen needles with you to take your insulin when you're going to be at work? That's where the problem solving comes in. It's very important because some people need to be taught those types of things. They might not necessarily have that inherently kind of built into their schedules, especially if you're working overnight and you're raising children.
Exactly.
And your spouse is also working a job.
And especially for our members who are healthcare workers, their schedules are erratic sometimes. So
Yeah.
Huh.
Sometimes there's so much to learn. So choosing a topic, I think, that maybe the patient identifies as a priority when they first step into the room, or if they're not necessarily sure, as we're working together and having a conversation, we might decide together, oh, this is the biggest problem right now. This is what we need to fix today.
Mm-hmm.
And then we can start working on other areas.
And you had mentioned earlier that the diabetes treatment is changing all the time.
Mm-hmm.
So what do you see as the future of diabetes treatment? We had begun this by saying there is hope. So what kind of good news are you seeing coming?
Well, I think that the newer medications on the market are having an impact. And also, certainly, I would love to see more oversight by the Food and Drug Administration on educating and labeling things better. They've definitely made improvements, but I think that that's something that would help diabetes.
Mm-hmm.
So then I think diabetes is changing because of the continuous glucose monitors. We're seeing blood sugars 24 hours a day, 7 days a week. And what's really wonderful with these new systems is if you get 14 days worth of data, that can generate an A1C because we're getting 24 hours worth of data, 7 days a week for 2 weeks. We can see, oh, well, when you came in last week, your A1C was 9.5. I do see that now your A1C is projected to be 8.7. So I can see where the improvements are happening. So I think that it's a window into allowing patients to have more advocacy for themselves and have more of a voice and more investment in their own care, right?
Mm-hmm.
And then I think the impact that the new class of medications are having, the GLPs ones and the GIPs, these medications are impacting patients because they finally feel like they're being seen and heard for how challenging it is to make lifestyle modifications. And so I think that it gives them the ability to kind of push through those challenging days and those challenging times because they see results sooner and they notice that they don't have food thoughts all the time. And I think it's putting more power into the patient's hand.
Mm-hmm. So all the new tools combined with empowering and educating patients is bringing about good news.
Yes.
So that's good news for our members and for the support that programs like yours provide.
Yes,
So
definitely.
Well, that's great. Thank you so much for the overview and for the good news.
Yes, thank you for having me.
Thanks for joining us. Tune in later this month to find out how Jessica supported 1199er Laverne King on her health journey. For more information on what you heard today, please check our show notes. And remember, subscribe to Health is the Key wherever you get your podcasts. This podcast and its content are presented solely for general informational and entertainment purposes. The information and opinions provided on this podcast are not intended as legal or medical advice and do not constitute or serve as a substitute for professional medical or psychological treatment, diagnosis, therapy, or other types of professional intervention.